Faris and Dr. Husna. Today I'll be presenting on common poisoning, supervised by Dr. Husna. And there's a few common poisoning that will be covered in this slide. But prior to that, let me explain the general management of all poisonings. So, ABCDE is very important, but at the same time, we should obtain the detailed history and also do physical examination. From the detailed history, if patient is conscious or cooperative, we can ask them specific agents, time, route, amount, and intent of exposure. If patient is uncooperative and altered patient, we can obtain information from family, friends, pre-hospital providers, police, and bystanders. Environmental clues also very important, such as empty pill bottles, suicide notes. And then if hospital records available, we can review any recent prescription or any history of psychiatric illness. And then we proceed with examination. First, by completely exposed patient by searching clothing and any personal possessions. And then we review vital signs and perform physical examination, full physical examination. We should focus on general appearance, level of consciousness, respiratory rate, pupil size, skin temperature, skin color. These findings might be suggest a specific syndrome, which I provide you guys a table of common findings of common syndrome at the end of the slide. Okay, and then our goal of management is resuscitation. So ABCDE is very important. So gross decontamination should be done prior to patient entry into ED. Care providers need to protect themselves with properly PPE. And then for airway, we should initiate airway protection first by assessing patient's speech. And then look for any airway obstruction and evaluate gag or cough reflex. Airway intervention first by opening the airway and then examining the oropharynx for any foreign body. If there is secretion, then we can suction. Oropharyngeal airway and also nasopharyngeal airway might be helpful temporarily while preparing for the unconscious and for the unconscious or absent gag reflex while preparing for the intubation. And then brief breathing, determine if respirations are adequate. SpO2 is very important, and then give supplemental oxygen if indicated. And then for the circulation, assess for blood volume status, CCTVR, most importantly blood pressure and also pulse. Then make sure the IV access. Treat hypotension with fluids first before vasopressor if patient still hypotensive. And then place patient on cardiac monitor and obtain ECG, as some poisonings might show sign of arrhythmia, so kita treat for arrhythmias. And then for disability, perform neurologic and mental status examination by assessing GCS score and pupil size and reactivity. Don't forget blood glucose and also temperature. So poison patient most commonly presented with altered mental status and coma. So These four are supplemental options in hyper or hypoglycemia, fluorazepam prolong. So the aim is to reduce. The first one is gastric lavage. Gastric lavage only consider if the patient has taken life-threatening amount of poison within previous 1 hour or is unconscious. And if only consider if there is strong cough reflex or airway is protected by EPP. Do not use gastric lavage in corrosive poisoning because of the risk of perforation, or with petrol or paraffin compounds, risk of pneumonitis. Cara dia, first we lubricate large disposable stomach tube, use 36 or 40 French scotch, pass it through mouth into stomach, and then confirm by aspirate gastric contents or blowing air down the tube while auscultate the stomach. And then perform lavage by pouring 300 ml boluses of warm saline, and then siphoning it tight and massage over stomach to help dislodge debris. While withdrawing the tube, occlude it between the fingers to prevent aspiration from tube.
Athirah.
Ya.
Kan tengok gastric lavage dekat ED.
Tak pernah.
Cuba pergi slide lavage tu balik.
Kalau patient kalau suspected poisoning, diorang kadang-kadang bagi activated charcoal je saya nampak.
Athirah, cuba go slide lavage tadi.
Ya.
Boleh tak back okay. So macam Dr. Husna tanya kan, pernah tengok tak lavage buat kat ED? Tak pernah kan? Stomach tube ni pernah tengok tak? Awak rasa besar mana 36, 40 French gauge ni?
Besar juga lah, sebab yang pasang chest tube tu pun dah 32 untuk hemothorax.
So this is actually bigger than chest tube size 34 tu. You know, it's like macam batang paip lah. It's not just your normal rice tube apa semua lah. So it's tak jarang dah lah ada benda lah ni. And it can be quite traumatic lah nak pasang. Gastric lavage ni macam it's in very specific situation je lah you consider gastric lavage. It's really out of dah tak ada evidence pun for the benefit gastric lavage ni. So tak tahu pun tak apa, tak perlu mention lah. Jangan duk fokus sangat dekat gastric lavage sebab takut nanti duk buang masa dengan nak cari tube tu satu, dan kadang-kadang tak tahu poison apa, and usually very rarely lah you get patient present within 1 hour of injection. So good to know, tapi tak perlu fokus kepada lavage sangat lah. Okay.
Next, induce emesis. Never use emetics. Diorang selalu guna syrup Epicate. Was once used frequently, but it may cause prolonged vomiting and aspiration pneumonia. So contraindic for less than 6 months. Reduce level of consciousness, absent gag reflex, or petrol compounds poisoning.
Yang ni pun
and then
pakai lah dekat tak induce vomiting lah because of the reason yang you bagi tahu tu lah, aspiration pneumonitis. Ni tak apa, sambung.
Yang selalu, yang kadang-kadang saya nampak activated charcoal lah, given within 1 hour, but dia punya downside dia very messy and unpleasant to take and often cause vomiting and aspiration. So adult usually 50 gram, children 1 gram per kg with maximum 50 gram. And then whole bowel irrigation, ni pun tak nampak. Cuma dia aim to empty the bowel rapidly of solid contents by giving fluid down the nasogastric tube. Using the
whole bowel irrigation. Tak pernah? Of course lah kan.
Tak pernah tengok.
Rasa dalam condition apa kita buat whole bowel irrigation? Poisoning apa?
Whole bowel irrigation. Tak sure.
Tak sure. Okay. Dalam pernah dengar apa? Body packer pernah dengar tak?
Yang mana apa?
Body packer.
Oh,
Body packer. Orang yang smuggle drugs tu kan, dia akan makan kan. Dia akan makan bungkusan-bungkusan drugs.
Keldai dadah ni lah.
Kedai dadah, ya.
Dia bor dadah dalam kondom ke, dalam beg plastik ke, lepas tu dia telan banyak-banyak to get pass through custom. That's body packer lah. Untuk poisoning per se, jarang orang, tak tahulah, orang tak buat kot whole body irrigation ni. Sebab whole body irrigation ni it takes time. Dia body packer ni buat whole body irrigation tu sebab kita nak keluarkan packets tu. Untuk clearkan dia punya, you know, dah dalam perut dia ada semua benda-benda ni, kita and literally whole bowel irrigation ni, awak tahu komod kan, yang wheelchair yang ada lubang toilet tu. Suruh patient duduk atas tu dan bagi ubat whole bowel irrigation kan, tunggulah apa yang keluar. Literally sampai keluar air tu. Dia bagi ubat tu dan tadah kat bawah tu sampai keluar air, then it's considered selesai lah. So kalau patient poisoning tu macam it's a bit orang tak buat lah. Tapi prinsip tu betul. Reduce absorption dan increase excretion lah. Tapi usually not by whole bowel irrigation lah. Tapi betul macam Dr. Husna cakap, kalau body packer banyak dadah, one of the bags dah pecah ke apa, and you want to clear the rest, yes, you do whole bowel irrigation.
Okay, then we proceed with specific poisoning lah. Ada organophosphate, carbon monoxide, paraquat, and also alcohol, methanol. So first, organophosphate poisoning, most commonly used in insecticides. For example, agricultural, animal insecticide in a household application. And organophosphate ni can be absorbed through the skin, lung and GI tract. So dia punya kerja inhibits acetylcholinesterase. So okay, sebelum ni saya akan terang dulu normal physiology. Biasanya acetylcholine ni dia stored in a vesicle, and then bila signal skin, dia pass through the membrane and go into synaptic cleft, and then attach to the receptor, leads to activation of muscles. And then if there is adequate activation of muscles, then acetylcholine will convert it into acetate and choline by acetylcholinesterase. So kerja organophosphate ni untuk inhibit the acetylcholinesterase, which results in ACH can unable to convert it into acetate and choline. So excess acetylcholine ni will keep on binding the receptor and increase the activation of muscles, which stimulates the nicotinic and muscarinic sites. So ini dia punya sign and symptoms. Can divided into three: muscarinic, nicotinic and CNS effects. So for muscarinic effects, cara yang senang untuk kita ingat, dumbbells lah, diarrhea, urination, mysis, bronchoria, emesis, lacrimation and also salivation. For nicotinic effects, muscle cramps, tachycardia, muscle weakness, hypertension, fasciculation and also hyperglycemia. And for CNS effects, anxiety, restlessness and tremors. Kalau teruk, convulsion and coma.
Untuk senang sekejap. Untuk senang dia punya apa? I mean the symptoms is kalau you tengok muscarinic effect tu, muscarinic receptor ni usually they present at the glands kan. So the presentation all about the wet thing lah. Diarrhea, urination, bronchoria, emesis, salivation. And then another thing, there are ada 3 condition yang life threatening lah in case of punya poisoning ni. Tahu tak? Orang panggil 3 killer bees. Ini very important lah. Maksudnya yang ni akan determine you punya direction of Korea lagi B
Bronchospasm.
lagi satu bronchospasm lagi satu bradycardia. Dia boleh ada
Bradycardia, so 3Bs. Okay.
tapi dia boleh ada juga bradycardia lah. Dia macam dia punya tu. Okay, boleh continue?
So there is additional effects of organophosphate. It can cause acute pancreatitis and also prolonged QT in ECG. In severe cases, can cause bradycardia, hypotension, and pulmonary edema. So for the investigation, like usual, baseline, and then do urine for toxicology screen, and then plasma cholinesterase gastric, and serum toxicology specimen. We can do ECG, chest X-ray, CT burn if indicated.
Plasma cholinesterase ni berapa jam dapat Athirah?
Lama.
Boleh hantar ke?
Ada tak dekat lab?
Boleh hantar ke? Lama tu 2 minggu ke? 2 minggu ke? 3 bulan ke?
Kalau tak silap saya dia kena outsource lah. Dia tak ada
yang toxicology, serum toxicology pun outsource.
So kalau tak ada result macam mana? Tak payah treat ke macam mana?
Macam doktor kata from clinical previous to clinical presentation lah.
Okay. Yalah tak kita tak depend on the plasma cholinesterase lah. Kita based on the history, dia punya clinical presentation, dia punya vital sign examination. Okay, proceed.
And then for the management, supportive measure, macam biasalah, yang paling penting all staff members required to wear protective equipment, and then start detoxification by removing patient's clothes and washing the skin thoroughly, and then maintain airway patency, inform intubation if indicated, and then frequent suctioning because of the bronchoria, and then administer supplemental oxygen, and then monitor vital sign, and also put patient on cardiac monitor, and then obtain ECG. Don't forget, establish IV access and administer IV fluids if indicated.
Okay, jap. Yang all staff members required to wear protective equipment ni kena stress bukan staff members je, doktor. Sebab korang selalu semua macam hero je. Pegang patient tak pakai glove, lepas tu ambil botol patient bawa poison, buka cium-cium bau organophosphate kan. Dalam presentation awak boleh cakap it can be absorbed via skin, via GI, via air. Sedut-sedut lagi kan. Lepas tu satu department pula nanti organophosphate. Pernah tengok patient organophosphate? You know how it smells. Kalau patient datang organophosphate yang jenis muntah-muntah tu, satu red zone tu akan bau organophosphate tu. Dia ada smell dia. So bila satu red zone tu bau, maksudnya it's in the air. So that's why sebab itulah kena pakai mask apa semua. Kan kalau tertumpah atas tangan, absorb, tiba-tiba awak pula organophosphate poisoning. That's why the importance of decontamination. Kan awal-awal cakap kan, buka baju, tengok poket, apa semua, search patient personal belonging apa semua. Itu bukan sebab nak cari duit dia patient bawa extra. Itu untuk make sure poison tu tak ada. Baju tu kalau tumpah atas baju dia apa semua, you remove the poison. And you kena pakai glove lah. Glove, apron semua kena pakai lah. Sebab you yourself is not exposed to the poison. Because some of the poison macam especially paraquat, memang absorb through the skin. Takut awak pula kena paraquat poisoning ke apa. Carry on.
Okay, ni for drug therapy. For antidote untuk organophosphate ada dua lah, atropine dengan pralidoxime. For the atropine, dia muscarinic receptor antagonist. So they act on muscarinic receptor, which has major use in reduction of bronchoria and bronchospasm. But dia tak ada effect on nicotinic receptor. Kalau patient ada paralysis, so it will not reverse lah. So adults to NGIV every 10 to 15 minutes as needed. And then children 0.05 mg per kg every 15 minutes as needed lah. So for pralidoxime, it works.
Sekejap Athirah, atropine, ada limit tak atropine? Kan kalau bradycardia every 1 mg 3 to 5 minutes, maximum of 3 mg. For organophosphate poisoning, ada limit tak atropine?
Macam tak ada, tapi sampai sign of atropinization tu lah.
Okay, so the key thing is tak ada limit This is not like bradycardia punya treatment. And the unit of atropine that you need tu bergantung kepada how bad the patient is lah, and of course berapa banyak patient consume the poison. This is not like 3 mg apa kan, dia cakap 2 mg every 10 to 15 minutes. Saya pernah patient organophosphate poisoning. Tahu tak berapa banyak atropine before dia respond? 100 mg. Habis satu department, kena korek dekat farmasi untuk baru respond. 100 mg untuk heart rate mata dia start dilate, heart rate dia daripada macam asystole jadi 60. Lepas tu you nak kena maintain pula dengan infusion. Jenuh lah nak korek atropine mana-mana lah. 100 mg tu satu department, red zone, yellow zone semua dah korek habis lah. Tapi that's what you need to remember. Jangan ingat dah bagi 10 macam dah banyak, kenapa tak respon lagi? No. If patient you kena bagi sampai patient respond, and it can end up being 100-200 mg lah. So bear that in mind. Memang dia cakap 1 mg every 10 to 15 minutes. Kalau nak tunggu sampai 200 mg 10 to 15 minutes, 8 jam lah nak bagi, nak cukup kan, 200 mg kan. So you can go a bit quicker, tak nampak tak respon, just every 2-3 minutes bagi je sampai patient response. And ni lah signs that you need to look for. Daripada dia peluh-peluh, kulit dia jadi kering, daripada dia brady dia jadi tacky, or dia jadi heart rate dia jadi 60-70, dan daripada ada bronchoria, secretion to clear up. And satu lagi pupils. Dari pupils dia constricted, pupils dia akan dilate. Carry on.
Next, pralidoxime. It works by reactivating acetylcholinesterase that has been bound to OP molecule. So effects on mainly at the skeletal neuromuscular junction of nicotine effects. So effects will be apparent within 30 minutes, which include disappearance of convulsion and fasciculation, improvement in muscle power and recovery of consciousness. Doktor, kalau biasanya kalau memang kita dah suspect organophosphate poisoning, biasanya kita bagi atropine ke pralidoxime, ke boleh bagi dua-dua?
Bagi dua-dua.
Saya tak pernah tengok organophosphate punya poisoning.
Pralidoxime ni dia kalau awak bagi lambat, dia tak, because of dia ada aging, dia kan act dekat acetylcholinesterase binti kan, and then dia leave the binding. So kalau you bagi lambat, dia dah ada aging tau. When the to acetylcholinesterase, dia akan ada aging. Aging tu dia dah aging, memang you bagi pralidoxime tak jalan. So basically kalau patient tu datang awal, boleh bagi pralidoxime dengan atropine jugalah. Tapi kalau memang dah macam dah lama tu, kalau you tak bagi pun actually tak apa lah tu.
Dia atropine tu yang penting. Lepas tu pralidoxim ni dia even dalam ni pun mention effect dia within 30 minutes. The life saving one tu is atropine.
Atropine lah. Okay.
Selepas airway breathing circulation the life saving one tu is atropine. Effect cepat. Pralidoxim ni you bagi pun dia bukan immediate effect dia. Dia macam synergistic dengan atropine. Boleh bagi bersama-sama. Dia bukan either one. Dia ni part of the treatment. The combination.
Atropine tu akan tackle the 3 killer beat bagi tahu tu lah. Yang tu yang akan cause life threatening to the patient kan. So kita and pralidoxim is not that easily available lah dekat ED. You kena order juga dekat pharmacy. Dia tak ada.
Okay. And then there is a form to reduce anxiety, restlessness and to control convulsions. Ada possible delayed effects in OP poisoning. The first one is
Skip.
Okay. Next we proceed with methanol poisoning. Methanol is an alcohol, colorless volatile liquid with distinctive alcohol odor. Dia can be found in windshield washer fluid, model, airplane fuel, photocopying fluid, perfumes and paint. It can be absorbed into the body through injection, inhalation, and
ada tempat-tempat ada dekat mana lagi yang paling easily yang usually cause of poisoning ni, selalunya kat mana methanol?
Solvent.
Before this outbreak yang dekat Kelang tu, kan masa tu you student lagi?
Tak ada student lagi, mungkin first posting.
Apa nak 2 years ago. Pernah dengar tak? Dapat di mana? Tak tahu. Teka. Tak pernah. Orang lain pernah dengar tak? Siapa yang ada dekat Sohab mana? Pernah dengar tak kes yang I think 2 years ago kot?
2 years ago lah. Ada dia benda ni akan happen periodically lah. Every couple of years akan ada sporadic outbreak of methanol poisoning. Why? I mean, jarang lah orang minum windshield washer fluid, model airplane fuel tu purposely tu jarang.
Alkohol biasa.
Ya?
Alkohol biasa.
Alkohol lah.
Kat Kelang tu.
Ni kena baca berita sikit, keep track dengan dunia luar, This is pre-COVID punya issue. What's the problem with alcohol kat Malaysia ni? Alkohol yang legal lah. Apa masalah dia kat Malaysia ni? Ada yang minum tak? Jaya minum tak? Nampak Jaya ada situ. Jaya ada ke?
Jaya minum.
Jaya kat Yellow. Tanya Jaya. I assume korang yang lain ni semua nama Melayu ni tak minum lah kot. Is alcohol cheap or expensive kat Malaysia? Alkohol yang minum tu bukan swap spirit tu. Alkohol, arak, beer, liquor dan sebagainya ni, is it cheap or expensive kat Malaysia? Cheap. Kalau cheap dia tak jadi masalah lah. It's expensive. Aku tahu satu can of beer cost berapa ringgit?
Tak tahu.
Kalau yang Guinness, lain kali pergi 7-Eleven tu bukalah tengok harga dia. Pengetahuan awam, buka peti sejuk 7-Eleven tu, tengok harga berapa satu can of beer. So, the one yang ada nama, it's usually dalam 10-15 ringgit per can. Tu beer tu consider macam Coca-Cola apa semualah. Macam Guinness apa semua tu, it's like 10-15 ringgit per can. Kalau awak pergi macam club, bukan saya pernah pergi club, tapi kalau pergi club, beli satu pint tu easily 50-60 ringgit lah. One pint of beer. So arak ni expensive. And for those yang biasa minum, usually macam yang culturally minum, untuk minum regularly ni mahal lah. Especially those yang tak kerja kaya raya ni. So what they do to dapat yang murah ni, they distill alkohol tu sendiri. buat sendiri. So alkohol ni technically boleh buat je sendiri. Tapi bila awak buat sendiri, alkohol ni nak jadi kepada alkohol yang boleh minum ni, dia benda yang sama je, dia akan lalu jadi metanol dan sebagainya. So if your distillery technique tu tak betul, atau you tak buat benda tu betul-betul, you akan instead of end up dengan alkohol, you akan end up dengan metanol. And there's no way for you to check. The only way for you to check, you minum lah. And I'm not sure how the taste tu betul sama ke lain ke. So bila minum, dia tak akan minum seorang-seorang. Dia akan bagi kat kawan-kawan, minum beramai-ramai. Then you end up with these people datang dengan methanol poisoning. Usually daripada arak yang buat sendirilah, at least kat Malaysia. Or beli arak murah. You know, arak-arak yang jual kat kedai biasa mahal, tiba-tiba ada kawan ni macam, oh ni arak seluduk ni. Macam you know, gudang garam yang seluduk tu. Ni arak seluduk ni murah sikit. Daripada brand, tak tahu brand apa lah. Cap api lah, cap kapak lah, apa semua. And these people yang daripada kilang yang dia punya QC dia tak bagus. So they end up with arak yang banyak methanol daripada alkohol. And bila these people minum, akan dapat methanol poisoning lah. That's how it always happen in macam cluster or ada outbreak. Sebab biasanya either among friends yang distill sendiri or among locally produced alcohol yang daripada you know syarikat kecil dari rumah lah, industri rumah ni. Tu yang kena ingat. Sebab tu history tu kena tanya. Ada buat arak sendiri kat rumah ke apa semua, kena tanya. So that can be contact trace. Oh, kena tu lah kata. Pergilah 7-Eleven, tengok sekali-sekali buka peti sejuk, tengok harga je. Bukan beli pun. Pegang tin dia tu tak kena samak. Okay?
Okay, Doktor. Okay. And then methanol ni dia can metabolize into formaldehyde and also formic acid, which are very toxic, and then leads to severe metabolic acidosis, visual disturbances, CNS depression. These are the classic triad lah. And then ada also has direct effect on the pancreas.
Okay, so apa yang korang nak kena faham, methanol itself is not poisonous. The byproduct of methanol bila dia tu didigest oleh alcohol dehydrogenase, that one is dangerous. So that's why the treatment ni kan ditulis antidote tu formiprazole kan. Tapi the other treatment for methanol poisoning is actually bagi alcohol.
Ethanol.
Sebab bila awak bagi ethanol, alcohol dehydrogenase ni will competitively digest alcohol. So the methanol will not be digested. So tak adalah formaldehyde dengan formic acid ni. So dia akan pass through urine. So that's why one of the treatment kalau and that's also why sometimes patient minum methanol pun tak mati-mati. Sebab dia minum methanol dan alkohol bersama. Minum banyak brand, and that sometimes leads to delayed effect. Kalau dia minum methanol per se sahaja, cepat. Kejap je nanti mata dia jadi tak nampak, koma apa semua. Tapi kalau malam tu dia party, tengah binge drink, dia minum pelbagai brand alkohol, so lambat sikit kadang efek dia. Sebab dia akan minum methanol, minum alkohol dan sebagainya. Carry on, sorry banyak menyampuk.
Dia punya peak serum concentration 30 to 60 minutes, elimination half-life 12 to 20 hours. So if patient consume 10 mils of pure methanol, may cause permanent blindness. Little dose dia 1 to 2 ml per kg. So symptoms begin 12 to 24 hours after ingestion. For CNS, can cause confusion, ectasia, depressed mental status, seizure, visual disturbances. And then cardiovascular, tachycardia, hypotension, and then respiratory, tachypnea, and shortness of breath, which may progress to respiratory depression or failure. And then GI symptoms, abdominal pain, nausea and vomiting, pancreatitis and gastritis. So macam biasa sama A, B, C, D, E, and then monitor patient, vital sign and ECG. DXT penting untuk possible hypoglycemia, and then send for blood investigation, and then determination of an iron gap and serum osmolarity. So the specific management, metabolic acidosis must be treated aggressively with IV sodium bicarbonate, keeping pH level 7 to 2 to 7 to 3. So the mainstay of treatment is fomepizole and also ethanol, because it's inhibit the alcohol dehydrogenase.
Fomepizole kita ada ke?
So tak ada.
Ha? Kita ada ke fomepizole?
Tak ada.
Why?
Mahal.
Yes. Really expensive. And belum tentu guna. Dia macam kalau simpan, takut dah expired dulu, baru tiba-tiba ada case. So, tapi certain place macam Kelang, West, selalu jadi benda-benda ni, adalah. Dia simpan sikit. Tapi fomepizole, it's prohibitively expensive. Dia mahal. So, the cheaper option is ethanol. Tapi kita IV ethanol pun kita tak ada. Kita ada oral, bagi ikut rice tube lah. Farmasi ada simpan, kena dilute apa semua. So, bagi, bagi minum lah. Bagi arak lah kat patient. So, even IV ethanol ni pun expensive. So, kita mabukkan dia lagi. Tapi yang penting fluids lah. Because a lot of the methanol ni akan dibuang melalui kidney. So, you want to eliminate sebelum dia digest into formic acid.
Boleh tengok sini toxic alcohol metabolism. Dia punya. Okay, and then hemodialysis for patient with severe metabolic acidosis that is not correctable, renal insufficiency and organ toxicity, worsening electrolyte imbalance and also hemodynamic instability. And then folic acid also can be used lah, may facilitate breakdown of formic acid. Boleh refer dekat yang gambar ni. Formic acid, dia facilitate breakdown of formic acid into carbon dioxide and water. Okay, next, carbon monoxide poisoning. Dia colorless, tasteless, odorless gas which acts as a respiratory asphyxiant that binds preferentially to hemoglobin and myoglobin. So that the affinity of hemoglobin 250 times greater than oxygen. So it shifts the curve to the left. So it results in impaired oxygen delivery, oxygen utilization, and also possibly accident stress injury in various susceptible tissue. So sources dia can be divided into endogenous and also exogenous. Biasanya carbon monoxide ni is normal degradation product of hemoglobin juga and other heme containing products. So carboxyl hemoglobin ni less than 5% in non-smoker, less than 10% in smokers, up to 2 to 5% in pregnant women, up to 4 to 5% in normal infants, 6% in hemolytic anemia. Kalau exogenous, cigarette smoke, fires, car exhaust, and paint removals, aerosols and fumigants.
Common bila kita nak suspect patient ada lalu kita akan suspect patient apa ni yang berlaku yang kita
history macam mana? Patient datang tu usually datang unconscious, tapi apa history dia?
Boleh biasanya early features boleh ni dia macam GE symptoms lah, nausea, vomiting.
Recently kan ada case. Ingat tak ada case dalam this year ke last year? Ada case satu grup perempuan ni travel dalam kereta beramai-ramai berhenti kat R&R.
Oh, tahu.
So apa history dia?
Saya tak ingat.
Tidur kat R&R tak bangun-bangun.
Saya tak ingat.
ingat tak kes tu macam mana? Cerita kes tu.
Cerita saya tak ingat tapi saya tahu ada kes tu.
So macam mana cerita dia? Cerita dia, mereka travel, lepas tu berhenti kat RNR sebab penat nak tidur. Lepas tu dah sampai malam, ayah dia call tak ada orang angkat. Ayah dia pergi cari kat RNR tu, jumpa dalam kereta. Semua tengah tidur dalam kereta. Kereta enjin hidup. So that's usually the history lah. Kalau nak suspect carbon monoxide poisoning, it's commonly one of the popular, tadi tak ada statistik lah, one of the popular cara bunuh diri lah. So because apparently it's relatively comfortable lah, macam tidur je. So you know, pernah tengok cerita Korea biasanya kan, ambil pipe, ambil getah, buh dalam exhaust, lepas tu bawa masuk dalam kereta, lepas tu tutup tingkap. Pernah tengok tak? Kalau tak, memang tak cukup tengok movie lah. Kena tengok movie banyak lagi.
Satu lagi, bakar benda dalam bilik, terunya dalam ruang.
Buat barbecue dalam bilik.
Korang takkan tak tengok movie Korea aku?
Itulah kata mereka ni memang study je kan. Korang ni memang study je. Bagus lah. So one of the ways is, you know, ambil pipe, buh kat exhaust, bawa pipe tu masuk kat cermin tingkap, tutup tingkap, dan tidurlah dalam kereta. The car will be filled by carbon monoxide. The other way, bilik tertutup, buat barbecue dalam bilik tu. Bilik tu akan dipenuhi oleh asap carbon monoxide, slightly less comfortable lah kot yang kereta tu. Dan the same thing happens to this this group of budak perempuan ni lah. The problem was, sekarang kereta ni kita tak tahu, kereta kita ni mungkin exhaust ada bocor sikit ke apa semua, you know, dan dia masuk dalam kabin. It's usually not noticeable masa kereta bergerak or masa aircon berjalan sebab ada gas exchange kan. Tapi bila kereta tu static, you know, macam parking tapi buka engine, then the carbon monoxide tu boleh terkumpul lah. After a while akan terkumpul dalam kereta tu dan menyebabkan makin banyak dia bind tu awak punya hemoglobin, and eventually awak tak sedar lah. And the issue with that is you don't realise. Dia bukan macam tak ada oksigen yang awak akan macam lemas tak. Dia awak jadi mengantuk, tidur dan tidurlah, tak bangun-bangun lagi. This also happen kat negara-negara macam kat Rusia kan. Kat Husna kat Rusia tu kan. Ada kan kes-kes gas radiator bocor apa semua. Pagi tak mai kelas, orang ketuk-ketuk tengok dah mati dalam tidur. Kat kita tak adalah sebab kita tak ada centralized heating. Tapi kalau tempat macam Rusia semua, it's fairly common jadi. Sebab kadang-kadang pipe-pipe macam ni, benda ni bila bocor kita tak tahu pun sebab dia bukan macam kan odorless, colourless kan. Dan dia tak menyebabkan simptom apa-apa, dia menyebabkan mengantuk je. Macam kita bila mengantuk tidurlah. So bila tidur tak bangun. So be careful, especially bila history tu, point dia, bila history tu unconscious, found in the car, by the roadside ke apa, found in the car ke, start to suspect CO2 poisoning. Okay, carry on.
In general, organs with relatively high demand such as brain and heart are more sensitive to the effects of carbon monoxide exposure. So kalau severe poisoning, patient came with coma with hyperventilation, hypotension, increased muscle tone, increased reflex and convulsion. Akan ada juga cherry red colouring of skin may be seen with fatal carbon monoxide poisoning, but rare in live patients. And then skin blister, rhabdomyolysis may occur after prolonged mobility, and then pulmonary edema, MI, cerebral edema may occur. Ni investigation dia, macam biasalah baseline semua. And then for the management, first of all, remove from exposure, and then evaluate and support airway, intubate if indicated, and then administer early 100% supplemental oxygen. monitor batasan, record ECG, look for arrhythmias and look for sign of MI, and then correct metabolic acidosis by ventilation and oxygen. Try to avoid bicarb as patient as it may worsen the tissue hypoxia.
Okay, so this is the situation where you nak bagi as much oxygen as possible. Sebab macam slide awal tadi kan, carbon monoxide ni dia lebih, hemoglobin ni lagi suka kepada carbon monoxide daripada oksigen. So awak kena bagi lagi banyak oksigen supaya competitively akan dislodge all the carbon monoxide. And it will go to your next slide tadi lah kan. So dah terlajak tadi sikit kan. So dan satu lagi, kalau patient carbon monoxide poisoning, kalau check SpO2 dia berapa?
100 full.
Kenapa?
Sebab
Kan patient tu unconscious, datang kata jumpa dalam kereta, doktor ada pipe pergi ke exhaust semua, tapi awak check SpO2 100% je ni. Kenapa? Kenapa SpO2 tak reliable dalam konteks patient carbon monoxide poisoning?
Sebab dia tak tahu.
Ada orang lain nak tolong jawab ke untuk Athirah? Abdullah ada kat sebelah kan? Abdullah ada idea ke? Sebab tadi macam selalu menyumbang kan, dengar suara sumbang.
Tunjuk.
How does your SpO2 probe to monitor your saturation? Pernah terfikir tak? Pernah tak tertanya, pernah terbaca?
No.
Hello?
Tak tahu.
Tak dan Google. Okay, so basically, perasan tak dekat SpO2 probe tu ada lampu warna merah?
Okay.
Saya baik perasan kan? Alhamdulillah. Nampak pernah juga pegang SpO2 probe tu. So the way SpO2 probe works ni, satu kan dia ada kepit kan? Satu akan keluar lampu, kat bawah satu lagi tu dia ada sensor. So how your SpO2 probe works is by yang atas tu dia keluar lampu, lepas tu sensor tu akan detect how much light pass through your skin. So based on that dia determine lah awak punya SpO2 berapa. Dia tak tahu pun oksigen ke carbon monoxide ke, dia tak tahu. As long as, because with carbon monoxide poisoning, patient tak jadi biru, patient jadi merah. Dia tak jadi sinus, dia jadi merah. Kan ada kan cherry red kan, cherry red skin dan semua. So for the SpO2 probe, the light absorption tu sama je, the light absorption criteria tu sama je. That's why so SpO2 dia takkan drop. So SpO2 probe tu ditipu oleh carbon monoxide lah sebenarnya. So SpO2 monitoring is not reliable in carbon monoxide poisoning. Tu je lah. Janganlah ingat saturation 100%, patient is okay. Not necessarily. Okay, carry on. Sorry.
Next, hyperbaric therapy. Actually ada kontroversi lah. Ada study tak ada show no benefit and suggested worse outcomes. Tapi ada study, ada hyperbaric therapy within 24 hours shows to reduce risk of cognitive sequel 6 weeks and 12 months after carbon monoxide poisoning. Ini saya tak pernah. Ni macam mana doktor hyperbaric therapy?
Ni kita tak adalah, ni adalah kes yang hospital lumut lah. Hyperbaric therapy is one of the dia indication lah, inpatient yang carbon monoxide poisoning ni dia ada itu dah macam yang dekat bawah dekat slide kan. So patient they will refer for hyperbaric oxygen therapy lah. Dia oxygen juga but hyperbaric under pressure, high pressure lah bagi.
Okay. And then we proceed with paraquat poisoning. Last poisoning in this slide lah. So paraquat is a toxic chemical that is widely used as an herbicide, primarily for weed and grass control. So macam mana kita boleh expose through intestinal ingestion. Dia very toxic if ingested lah. Death is likely after 10 ml of liquid paraquat. Long-term skin exposure may cause erythema or sometimes ulceration, but really sufficient to cause systemic toxicity. And then from inhalation may cause sore throat and epistaxis, but not systemic poisoning. So after absorption, paraquat ni dia concentrated inside many cells with where it undergoes redox cycling. Redox cycling is a process involving repetitive enzyme magnetic cycling between paraquat and paraquat radicals. So they produce superoxide radical, which is a highly reactive oxygen species, which then can cause direct cellular damage.
Apa nama glamour paraquat ni? Usually kalau patient datang, dia takkan cakap dia ambil paraquat, dia cakap apa selalunya? Dengar?
Racun rumput.
Apa skemanya? Okey, paraquat memang warna dia memang warna hijau sangat. Patient selalunya kalau dia ambil paraquat tu betul-betul, memang akan ada stain hijau ni lah dekat mulut dia, dekat tangan dia, dekat baju dia. Yang ni bahayalah, memang kena decon patient lah, remove dia punya tu, basuh dengan air. Kemudian another thing is usually the term is cmeho. Jadi kalau patient datang kata cmeho tu, boleh fikir pasal paraquat lah. Tapi tengok juga dia punya, minta botol apa yang dia pakai tu lah, minta ambil gambar. Yang tu common term, orang kata datang makan racun rumpai macam.
It's fairly common dekat Sungai Petani ni, fairly common punya racun juga dekat Sungai Petani ni. Just be aware. And the last paragraph tu, this is the reason why kalau patient paraquat poisoning, unless necessary, tak perlu, jangan bagi oksigen lah, because it may worsen the lung fibrosis apa semua. If unnecessarily, jangan bagi oksigen. I mean, kalau kena bagilah. Tapi if tak perlu, jangan bagi, because it can cause whatever superoxide radical dan sebagainya ni.
So paraquat ni very corrosive lah and cause immediate burning pain in mouth and throat, nausea and vomiting, followed by abdominal pain and diarrhea. If consumed large amounts, can cause rapid deterioration with shock, pulmonary edema, metabolic acidosis, coma, convulsion and death within 24 hours. Kalau smaller amounts, dia biasanya tak produce shock. Dia after 24 hours, chemical burns dekat mouth and throat causes pain and difficulty in swallowing and speaking. So renal failure can happen, occurs at 1 to 2 days, presentation of jaundice. And then paraquat lung, biasanya lung are the main target organs lah. 60 to 80% of the cases because of the acute lung injury and also pulmonary fibrosis. So macam biasa, investigation, urine for paraquat, baseline investigation, ABG, chest x-ray. Management ni sama je. Contaminated clothing should be removed immediately. Skin should be washed with soap and water, and then insert nasogastric tube. Stomach washout as soon as possible. Can give activated charcoal, and then give drips, potassium supplement, furosemide, and then any oxygen to be avoided lah, unless PO2 falls less than 60 mm 60.
Kalau tak silap, more than 88 is acceptable lah. Kalau less than baru bukan PO2, SPO2 sorry.
SPO2.
Dan 88 baru bagi oksigen lah.
Okay. That's all my presentation. Ini common findings in each toxidrome lah. Ni reference saya.
Okay, ada soalan kepada Athirah? Athirah, ada take home message, moral of the story ke? Tak ada moral. Saya bagilah moral of the story. So principle of management of any poisoning, general principle lah. First, decontamination. decontamination of patient, decontamination of yourself ke dan sebagainya, decontamination. Yang kedua adalah reduce absorption, bagi charcoal ke lavage ke whatever lah. Ketiga, increase secretion, either awak nak buat whole bowel irrigation ke, nak bagi apa fuller's earth ke apa semua. Dan yang keempat adalah specific antidote. Kalau tak ingat apa-apa pun daripada lecture hari ni, daripada presentation Athirah hari ni, these are the 4 principle of poisoning management. Decontamination, increase secretion, reduce absorption, increase elimination, dan specific antidote. For any type of poisoning, if you follow this principle, insya-Allah tak sesat jauh lah. So sebab nak cover all the poisons dalam dunia ni, oksigen pun boleh jadi poison kan, if higher concentration enough kan. So a bit difficult, tapi secara prinsip dia itulah. Okay, thank you Athirah. Sorry saya banyak menyampuk.